Welcome. Thank you all for joining us for today's presentation of Grand Rounds presented by the Department of Psychiatry and Behavioral Sciences. If you're just logging on, surprise, you can see we're coming to you today from campus. So I have Dr. Rappaport to my right here, live and in person for us in the room anyway, and we'll introduce you in a moment. But as people slowly log on and join the webinar, I'll go over a few details about our Grand Rounds series. First of all, today's presentation is sponsored by the Garvey Institute for Brain Health Solutions. We will have a survey for you at the end of the presentation today. So if you're interested in giving us some feedback, as soon as the webinar closes, you'll see a link to that survey. So please go ahead and click that. We invite you to join us again next week. We'll have another Grand Rounds on Friday, the 18th, same time, same link. So please join us for that one. And want to let you know we are recording today's presentation. So if you've missed the beginning of it, it will be available soon, either this afternoon or sometime on Monday on our Grand Rounds archive page. So look for it there. Before we begin, just to let you know, we do have the Q&A feature activated today. So if you have any questions, go ahead, type those into the Q&A at any point. We'll queue those up. Try to leave a little bit of time at the end, and we'll go over those questions for you before we conclude today's presentation. So with that, I think you can see across the table from me, we have the chair of our department, Dr. Jürgen Unitzer, and he is going to introduce today's speaker. So with that, I'm going to hand it over to you now.
Great. Thank you, Jed. Good afternoon. Welcome to Grand Rounds, everybody. So today I have the really great pleasure to introduce a good friend and colleague, our Grand Rounds speaker, Dr. Mark Rappaport. There's a lot I can tell you about Mark, but I'm going to try to make it kind of brief, but just a few things. So Dr. Rappaport is a psychiatrist. He's a truly accomplished clinician, scientist, teacher, and administrator. He trained at UCSD. And then at the NIH, and he went on to have a really remarkable career as a clinician, as a clinician scientist in clinical psychopharmacology and clinical neuroscience, fascinating work in psychoneuroendocrinology and a whole bunch of other things sort of in the larger realm of clinical neuroscience. Mark has been the PI of dozens of grants from virtually every major funder in the area of neuroscience, and he's authored more than 200 articles. He's edited 4 books. He currently edits the APA journal Focus, which helps busy clinicians stay up to date on psychiatry. And he's also mentored dozens of clinician scientists in areas such as clinical psychopharmacology. Mark has served, among other things, as a department chair in 3 departments of psychiatry, most recently as the chair of psychiatry at the University of Utah, where he was also the founding CEO of the Huntsman Mental Health Institute at the University of Utah. During his time there, Mark led the expansion of clinical programs in crisis care and several other really interesting clinical programs. He helped launch a remarkable translational research building on the University of Utah campus. He's built some amazing partnerships with colleagues in schools and education and other community partners. And he also helped initiate some really creative efforts to take on the stigma associated with mental health. And that's what he said to me at dinner last night. He plans to make that important area of work of a major area of focus as he becomes the president. He's now the president-elect of the American Psychiatric Association. And that's the work that I asked him to share with us today. So, and I think it's incredibly timely because we find ourselves now at a really critical time where many of the things that we hold dear as clinicians, as scientists, really are being questioned. And I think we are super fortunate to have Mark help represent us as a field, help bring us together with colleagues in psychology and other related fields to really advocate effectively for the work that we do with individuals and families living with mental health and addiction problems. So with that, I'm really happy to welcome you to UW Psychiatry, and to do our Grand Rounds today. Really look forward to your presentation, Mark.
Well, thank you very much, Jürgen. And it is really a pleasure to be here today. What we're going to talk about is flipping the mental health dialogue. and why now is the time to do it. And I need to preface this talk by telling you a couple of things. One is it's Jürgen's fault, because Jürgen was kind enough to come and give grand rounds at the University of Utah recently. And during our time there together, he said to me, Mark, I really would like you to come and speak about this topic. And so I said, okay, I will. But this is the first time I've ever given this lecture, and it was really stimulated by our discussion. And so I'm pleased that this is the place for the inaugural lecture. Now, you all know this. We really have an urgent need to address diseases of the brain right now. As we'll talk about in a minute, and you all know how prevalent these diseases are, how disabling these diseases are, and also that we don't have enough people to take care of folks. It truly is a tsunami. Looking at old data. Now, the next few slides I deliberately put in, and they're slightly older slides, because what this represents is actually a conference and the result of some work that Jürgen and I did when we spoke at a symposium put together by the Blue Ridge Group. But we know prior to COVID, more than 1 in 4 individuals in the US suffered from a major psychiatric disorder. We know that even before COVID, the greatest cost in terms of spend were mental disorders, not heart disease, not trauma, not cancer. We know that mental health and substance use disorders, both in the United States and worldwide, is the greatest cause of disability there is in terms of disability adjusted life years. We also know that there's been this precipitous drop in mental health beds throughout the United States. Jürgen was nice enough to show me your new facility, which is absolutely spectacular. And it's also designed in a way that brings our patients, as well as ourselves, dignity and respect. Because too often, individuals with mental health and substance use disorders are incarcerated. The 3 largest mental health facilities in this country right now are the Twin Towers Jail in Los Angeles, the Cook County Jail in Rikers Island. There's been this precipitous decrease in mental health beds and an increase in incarceration, an increase in saying that diseases of the brain somehow are illegal and immoral. At the same time, because of the freeze in number of residency slots nationally, we're seeing a decrease in the number of individuals who are psychiatrists. If anything, with all the mental health problems we have, we need an increase rather than a decrease. But many programs have actually taken GME slots away from psychiatry and put it into orthopedics, put it into neurosurgery and other areas instead. And then came COVID. With COVID, as you know, the ramifications in terms of personal isolation, anxiety, lack of agency, the fact that all of a sudden, mortality really thrust itself into people's faces. There are professional challenges there that occurred. Lord, all you need to do is think about how many of our colleagues in healthcare were demoralized, committed suicide during this time of COVID. It exacerbated unemployment and social disparities. And it also created the environment we're in today. The whipsawing effects that are going on right now in this country, and also the way our country has become fractured instead of focused on supporting each other. For our patients, there was tremendous isolation and suicide. Our health systems, we're all dealing with it today, how overwhelmed the health systems are. When we look at the debt and deficit that occurred because of this. And people didn't know how to respond to that. We also, our health systems were not prepared for truly having a pandemic. And we're still dealing with the ramifications of that interpersonally. And then nationally, unfortunately, the xenophobia that's occurred, the isolation, the fracturedness, really has affected our country. And it led to the second pandemic. The fact that our health systems, the first responders, essential personnel, the public had to cope with loss and grief and isolation and a lack of sense of control and agency in ways that they've never had to before. You know, the isolation and survivor guilt that occurred has just been massive. And then for our children, their lives were completely disrupted. You know, to go from a sense of omnipotence, which is part of childhood, to a circumstance where children are seeing other children get sick and die, seeing people they love get sick and die, seeing the structures that normally gave a sense of stability really get shaken at their foundation. And this has led to, as the former Surgeon General said, a true pandemic for our children in terms of the frequency of anxiety, the frequency of depression in the young folks. There were certain surveys that suggested that up to a third of high school students had considered ending their own lives during the pandemic. And up to 10% actually made some type of attempt. But what this also set up was an appreciation in the public and an appreciation in our colleagues that there's a bidirectional interaction between the mind and the body. Yeah, that's why God made the neck. But it was really important because it led to a circumstance that we've never had in our country, a circumstance where all of a sudden the mental health needs, be it because of the opioid crisis and fentanyl deaths, be it because of the pandemic and what it did to all of us in terms of our sense of being immortal, all of a sudden being shaken to the core with over 1 million people dying. It led to a place where all of a sudden people were interested and willing to talk about mental health and willing to think about mental health differently. That led to what I'm going to show you, which is actually 3 different initiatives that we launched at the Huntsman Mental Health Institute, around getting rid of stigma, around really looking at ways to communicate this message more effectively. And then a third initiative that is focused on monetizing the social impact of what we do in our field. And so that's what the rest of this talk will be about. One of the initiatives we launched in 2022 was Stop Stigma Together. And the reason for this is that the stigma related to mental health and substance use, the fear that people have, you know, as I digress as usual, back in the old days, when I was a medical student, I was tortured on my surgery rotation. And the surgeons were very big and strong and powerful and loved to torture medical students back in the dark ages when I had dark hair. And then I was doing a psychiatry rotation on a locked inpatient unit and got to watch the surgical consultants come onto the unit. And they were terrified. They wanted to get out of there as fast as they would. They wanted to be as far away from those patients as possible. But that stigma and fear and ignorance and prejudice. Remember, our patients die with SMI 25 years earlier, not because of psychosis or bipolar disorder, but because of untreated medical conditions. The stigma decreases reimbursement rates, they decrease access, they decrease access to health or appropriate health care. It's a huge problem, and it leads to suicide. It leads to shame and guilt and people being reluctant to get care or to realize that diseases are the most beautiful and wonderful organ system in the body, the brain. Not a simple pump like the heart, not a filter like the kidney. I'm not going into the GI tract. But diseases are the most amazing complex organ system in the brain are somehow considered a personality weakness or a flaw. Somehow, if you just tough it out, no, you can't tough it out. But that shame and guilt leads to death. It leads to destruction of families. That leads to poor access of care and tremendous inequalities in funding. So the question is, how do you deal with this? How do you begin to change these cultural and societal problems that we see? And all you need to do is look at the paper, because look at all the headlines that we're dealing with it. So now is the time to do it. Well, there are a couple of steps that are necessary. One was this report. This came out in 2016, actually. And this was the National Academies of Science and Engineering Medicine report on stigma in mental health and substance use disorders. And it defines 3 types of stigma: structural stigma, public stigma, and self-stigma. And that all 3 of these need to be addressed. Structural stigma is the fact that in 24 states in the United States, they ask whether or not you've had a mental disorder or seen a psychiatrist when you're getting a medical license. Public stigma, we all know so well. We've seen it. We've seen people ignored who are clearly in distress and suicidal. We see people criminalized because of substance use disorder. Self-stigma, the fact that the majority of people don't seek help, the fact that they don't understand that it's not any different than a heart disease, but a disease of your brain. So how do you tackle something like this? How do you create a social movement that deals with these types of complex structural issues on so many different levels? Well, Christina Economos, and she's actually giving a public lecture very soon. That's a national lecture. But she's done all this work. She's in Boston, and what she did was identify the factors that facilitated seatbelts becoming the rule of the land, facilitated the success of anti-smoking campaigns. And what she identified were that there were about 10 factors involved. Some of them are around framing the crisis and around building the case about why you need to fix this problem that is so big. The second set of activities are around creating the alliance, creating a plan with folks, developing champions, creating and building a coalition. And then the third set of activities are around advocacy and communication and creating an environment for policy change. This is the approach that we've taken with the Stop Stigma campaign. We've been fortunate to have an expert who did Healthy Nurses, Healthy Nation, Seth Kahn, partner with us, and also Dr. Daryl Kurtz, the former CEO of the AAMC, is one of our active partners in this initiative. And so if you're creating a collective impact model, what you want to do is a sustained movement that's going to last 10 or 20 years. Because these changes don't occur over time. And the key components to this include a steering committee that sets the strategy and vision and governance. And these are members of our steering committee. Working groups that look at metrics, that look at funding opportunities, JEDI. We can still say that in this state. We can't say it in Utah. Actually, we can't. It's illegal. And communication. Backbone organizations. We have over 300 organizations that are partners in this, as well as community activities and interest groups that really, so for example, we have interest groups that focus on mental health in the workplace and stigma. They focus on the entertainment industry and stigma, and the fact that the mental health, the way mental health is portrayed in our media, and particularly in the film industry and other industries, is more derogatory and pejorative than it is positive. And there actually is work out of the Annenberg School at SC that looks at that and is created an initiative. And that's one of the working groups we have looking at that and how you can change that with writers and actors and directors. But the intent of SST, of Stop Stigma Together, is to facilitate the success of the other organizations. So there are many organizations, be it SAMHSA, which still kind of exists, the American Psychiatric Association, the American Psychological Association, NAMI, and many organizations have some component of their work looking at stigma, but they have many, many other activities that they're involved in. So the intent of a successful social impact sort of backbone organization is to serve as the conductor for all these instruments that are being played, to facilitate them coming together in terms of certain consistency of message. It's not to direct the message. It's not to say that we're creating the message, but rather to facilitate communications, facilitate synergies, and ensure that everyone knows what the other person or organization is doing, and also that there's a commonality in that message, certain common tenets that are part of it. This is our leadership team for this organization. This was our first design summit where we brought people together in April of 22 just to say, are you interested in participating? Does this make sense to do at this time? And would you be willing to participate? The response was yes. And that led to this event that occurred in October of 22, where we brought 130 organizations to Snowbird and had a 2.5-day meeting, saying what folks were doing, how they could collaborate, and how one could bring them together. That led to a Children, Youth, and Family Summit that occurred in 23 in New York City. And we were able to get the Big Bird and Sesame Street Workshop involved in partnering with us there. We were able to collaborate and get partnerships from the Hazelden Betty Ford Center, talking to folks from the Child One Mind, and really facilitate again engagement and interaction. And if you remember in 23, Sesame Street Workshop began to create public service announcements about mental health and child mental health. In 24, last summer, we had again a 2.5-day summit with several hundred groups involved in that. And we've used that to create a series of national interest groups or communities of practice that we call them, around veterans, criminal justice, workplace, And anyone's able to participate in these groups. And they have regular meetings and are moderated and such. And one can reach this and be part of this network by just going to ssc.com. We have open source tools and a host of ways to facilitate communication of individuals and of organizations across groups. In fact, we had a lot of support in the past from OSHA because they realized that mental health was a major problem. This leads to the second initiative that I wanted to talk about. And literally, we got to know the Ad Council because of these activities in SST, and the Ad Council and frankly, folks from the American Foundation for Suicide Prevention who introduced us to the Ad Council said, look, the Ad Council has finished what they're doing right now in terms of COVID, but have decided that mental health is where they want to go next. And we embarked at the Huntsman Mental Health Institute in reaching out to them and created a partnership. We put in $15 million towards this $65 million initiative that's called Love Your Mind. And what it really is a campaign that where we look at partnerships across every sector in order to begin to change social norms and reduce the stigma around mental health. And let me, words are great, but actions are better than words. And this is the first ad that we put out.
If you know that I want the best for you. Doing big on himself too. Can't just rebound from everything. I know you've been grinding. Let's go. So, I wonder if you know that we can get help. I've waited so long. But see how far we can go.
%59% of adults with COVID have said that they had a mental health condition. Less than half are getting any type of help or treatment, let alone effective help or treatment. So the goal of what we were doing is to reduce stigma and make taking care of mental health a priority for people. There are three components to the campaign. There is normalization, demonstrating that making mental health a priority makes sense. Changing perception around seeking help, who seeks help, and that it's a strength to do it, not a weakness. Educate, to facilitate individuals having knowledge, for oneself and for others, and really helping people understand what's available, and then connecting folks to resources that are culturally specific that they can use and are appropriate in order to facilitate their mental health. Our target audience was initially young people 18 to 44 who are struggling with their mental health and hold attitudes and beliefs that may discourage help-seeking behaviors. Now, one of the, I'm a dyed-in-the-wool academic. You heard from the wonderful introduction that Jürgen gave me. But what I've learned working with the Ad Council is just how sophisticated the assessment and of the population, the Ad Council and advertising and big industry media is. They're far more sophisticated than many of our departments of our schools of public health, because what they've done is cherry pick some of the best people out of those schools. These are the 6 psychographic segments that the ad council and their team, and they literally interviewed hundreds to thousands of individuals, developed. What one sees on the x-axis is sort of a listing of sort of the way that people think about mental health conditions. And on the y-axis, it's whether people perceive it as positive or negative. And what one sees is that there are these 6 different components. We're going to focus in on the down and dug in, because these are individuals that are having problems and are struggling, but don't believe in mental health and don't believe that they should get help and are most resistant to it. And the silent and solo are individuals that are suffering, but do so in silence and alone, and feel tremendous shame and guilt. The don't burst my bubble are individuals who are in tremendous denial about that mental health problems exist, period. And that everything's going to be okay. We just don't talk about it or deal with it. If we look a little bit more in detail at this, again, the crisis crew are folks that are struggling and know that they need help, but aren't sure where or how to start. And so the goal there is to facilitate them getting access to help. The down and dug in are individuals that have a negative view of mental health care. And I'm really, really concerned about judgment. So they're one of the groups that we wanted to focus on first, as were the silent and solo. These ignore their feelings and struggle, but feel like, well, that's the way my life should be. It's just going to be a struggle. There's nothing I can do about it. These other 3 groups are more positive. But again, the don't burst my bubble has less empathy about mental health struggles and doesn't really understand that these are disorders of the brain and these are disorders of the body as real as any other disorders. So the challenge we faced is that the audience didn't see tangible value of caring for their mental health. So the work we've done, be it that first ad that I showed you, is really strategically focused on helping people understand that by taking care of their mental health, it's an asset towards success. So these are the components of a successful campaign. And again, we're grateful to the Ad Council to work with us. Exposure, awareness, engagement, and impact. We look at exposure.
Everyone has a ritual. That small thing to keep us focused. A habit we never skip. To clear our minds and elevate our performance. To drown out the self-doubt and support your mental health. Maybe you surround yourself with positivity. Or you need to center yourself. Because being your best isn't just about taking care of your body. It's about taking care of your mind and mental health. Discover the resources you need to keep your mind focused and your mental health a priority.
This ad was first shown May 30th of this year. It involves 11 professional sports leagues. This campaign has had over $63 million in donated media this last year, since May. This campaign was shown during the World Series. It was shown during NFL football games. It's shown during basketball games, both for the WNBA and the NBA. It's been shown on Meta and other sources. And there were over 712 million impressions for this ad and this component of what we were doing with Love Your Mind. If you look at the overall campaign during the first year of it, there's the focus on television, the focus on digital media, different types of PR that was done, social media, and then out-of-home media with Uber, with the taxis throughout New York City. And this campaign during its first year of implementation had 5.2 billion impressions. But if you look at the partners in this is what makes it successful. ESPN, Facebook, Pinterest. And this is the advantage of working with the Ad Council. The Love Your Mind campaign and ads ran in 100% of US markets since launching. The Love Your Mind campaign was the most successful mental health brand effort this last year. More successful than, the BetterHelp, more successful than the veterans programs, Calm, all the other programs that occurred over this last year. And what's really important are data like this, where over half the adult population between the ages of 18 to 44 in the United States became aware of the campaign. And if you look at the specific socio-demographic groups that we were most concerned about, what you see again is that large components of the down and dug ins, over 60%, know about this campaign and have had access to it. And if you look at some of the other groups that we were concerned about, the silent and siloed, or rural populations, again, what we see is significant uptake of this campaign in 1 year. If one looks within different demographic groups, one sees that over 70% of Black and Hispanic individuals that men who fall into the down and dug in category were reached by this approach. When we look at the silent and solo, and we also did a rural campaign, because as you know, the rate of suicide in rural populations is 4 times that of what an urban population is. If one looks at engagement, we had over 1.3 million visits to the website. And even more importantly, over 100,000 people click through to get access to the resources we have on that website. These are just examples of some of the types of materials we had there. I'm not going to play for you because of time, those 2 radio ads there, but those are radio ads. Love Calm Your Mind and Casey Field and a radio ad he did. You're wondering who Casey Field is, I see in this room. Well, 1 second, I'll show you. But these are the KPIs. When one looks at the who's aware of the campaign in the general population, and whether if they've been aware of the campaign, they're actively interested in taking care of mental health. 77% of the general population that have seen the campaign feel that way. 70% of the down and dug in. 68% of the silent and solo. If we look at is it a sign of strength to get mental health? Again, you see positive interactions that occur because of the campaign compared to a subset of individuals that have been appropriately sampled that did not know about the campaign. So in this first year of operation, based on the work that our colleagues, the Ad Council, have done, they considered this their most successful campaign that they've launched in years. And you were asking about Casey Fields.
Being a cowboy. I don't know anything different from when I was 3 or 4 years old. I did tough things, and not everybody did tough things. I didn't have time for it. I had a very successful career at a very young age, and life is fast. I was preparing physically, I wasn't doing anything mentally on the inside, and then I got hurt. I wanted to be better as a person, and I really dug into mental health. I start my day with 20-minute workouts. I live life 8 seconds at a time. Horses are so therapeutic. They know what you're feeling. When you're nervous, they're nervous. You won't sit back, but for pounds. I take a lot of responsibility in taking care of my kids, my family, being there. You're gonna have tough days. Everybody does. Find a place to stop and just breathe. Love your mind.
That's Casey Fields. And what he was able to do with us is launch these ads at the National Rodeo Championships. So they were able to show these ads on the screens there and hand out materials to that audience about it. We did the same thing with the Farm Bureau. And the annual meeting of the Farm Bureau, which had over 4,000 individuals, was in Utah last year. And we have specific ads that are farmers talking about their circumstances. And we were able to share that at their national meeting and be part of it. So what you've seen to date are 2 different related approaches to deal with stigma. Looking at how we address particularly social and self-stigma, and to a certain extent, institutional stigma. But this third initiative was really developed to look at that. And so we're working with the Sorensen Impact Institute and our health economists. We've been developing a framework and an economic model that monetizes the social impact of everything we do in substance and use and mental disorders. So as you know, we're an underfunded and neglected field. And so what this approach allows us to do is to monetize the benefit of our services, our research, and our education, not only for patients, but at the insurance company level, the government, all levels of the government, society as a whole, and of course, within the framework of the health system. So in 2023, we engaged in a partnership with the Sorensen Impact Institute and the Health Economics Core at the University of Utah to begin this process of how do you monetize the social impact of what we do? These are the steps involved in monetizing it. And then I hope that by the end of June, we'll have the first draft of this actually published. You create an inventory, review all existing services programs from education to different clinical services to research. Then there's a literature review, the development of impact indicators and mapping those indicators. And we'll talk about that more in a minute. Initially, 23 indicators were identified, but because of the stakeholder interviews and conversations, another 33 were identified. And then there was categorization of these various indicators. This then led to a phase of data recruitment and identification, where based on all of this, we spent a lot of time going through our databases, going through publicly available databases, collecting those data, and also understanding where there were gaps in our data. Because the goal of this is not just this retrospective analysis of where we are and where we're going. The goal is to create prospectively an approach that allows you to understand the social impact of your programs or lack of social impact, and what works and what doesn't work. And of course, program identification. This led to a mapping process where they looked at the direct and indirect indicators of social impact, and then allowed them to create an inventory of not only the data gaps, but what data were available and what data were important in order to monetize the social impact. And what you see on this slide, and I apologize, it's very busy, but the 23 major sort of indicators, direct indicators. And then what there is a listing of what programs within HMHI is appropriate for each of the indicators. And so programs, of course, may have many of these indicators, direct indicators that are ones that are part of them. But by doing this, we can begin to then set up an approach that allows us to look at patient level measures of improvement, be it for access of care, health status, or lives saved. We have a very large suicide prevention program, which we don't have time to discuss today, but it really is a statewide program that's very effective. Financial measures, reduction in emergency room visits, inpatient utilization, both within the general hospital and within psychiatric facilities. Societal measures, looking at diversion from criminal justice, increased activity in the labor market, and scholarly and health professional impacts as well. So it's a really comprehensive analysis and plan that we have. I want to just give you a couple of examples of where we're going with this. And that's going to lead to me wrapping up the talk for today. As Jürgen knows, we just opened this month an 82,000 square foot crisis care center. This is the design of the crisis care center is completely unique. We added a third floor with a free legal clinic, free dental clinic, a free medical clinic. We added room for our community partners, room to help people get enfranchised and on Medicaid. We added a PHP, a substance use program, as well as the building was designed for both training, all types of specialties, from peer support, through nursing, through PAs, through psychologists, social workers, through physicians. It was designed deliberately as a prototype that could be used for where we think crisis care needs to go. So there's a 24-bed inpatient unit that complements our 161 inpatient beds. 3 pods of 10 for crisis stabilization. But in order for us to figure out what we were going to do before that, we spent 2 years in a prototype. We saw about 4,000 people in the prototype. What we were able to show is that once somebody was seen in our prototype crisis care center, we decreased ED utilization by 64%. 2.7 ED visits for any cause for a person that had been seen in our receiving center. A 61% decrease in ED-related healthcare costs, an 83% decrease in inpatient utilization, and a 66% decrease in inpatient-related healthcare costs. The other thing that we were able to notice for the community is that if somebody is seen in a general hospital emergency room, at least in the state of Utah and many other states, if they're brought in by law enforcement, they have to wait until disposition, law enforcement does, before they can leave. That's an average of between 6 and 8 hours. That's 6 and 8 hours that law enforcement is not out on the street. It is a massive increase in overtime pay because they cannot leave until that disposition occurs. With our prototype crisis care center, it was less than 5 minutes. you think about the dollar savings for cities, for counties, for states by doing that. That's part of the argument for what we do. Now, we do not have the type of wonderful and perinatal program that you have here at the University of Utah. We're in the, excuse me, at the University of Washington. We at the University of Utah are just at the nascent phases of developing it. Nothing like what Jürgen was telling me about, which is really, really impressive. However, we took 61 cases in our prototype. Using available published data and other direct indicator data, we were able to estimate that by intervening and doing this, both mother and child, looking at the savings for the dyad, was about $36,000 per dyad. So in our 61 cases, if you look at all types of savings, whether it's going back and being productive, whether it is decreased problems that the infant has, all types of savings, it's over $2.2 million. This demonstrates that mental health is an investment, not a cost. And this is the argument that we need to be making with our colleagues, with our health systems, with our insurers, with our legislators. So what we were able to do is begin to generate extensive data that shows that the social and economic benefits to patients, families, and societies, and that these benefits have both short-term and long-term financial savings for payers and for communities. There's a need, and one of the things we're working on now is enhancing and improving. And in fact, I have a faculty member, I gave $500,000 to ensure that we're implementing the right measures so that we can prospectively use this approach and these data to demonstrate the value, or and I have no problem because I've done it in the past. If something doesn't work, get rid of it because you have to. Resources are limited, but you need to know whether it works or doesn't work. And that's the intent of this prototype with the Sorensen Impact Center and our health economists. Again, we hope to have the first iteration of this model available for the public to use this summer. So in conclusion, now's the time to change the dialogue around mental health. There's a sense of urgency that our patients, families, and the profession has. There's a greater national and international understanding of the importance of mental health and brain diseases. In fact, some of the work that we've been doing, we finished a project with the Kennedy Forum where we went through all of the laws and programs in the state of Illinois. The state of Illinois paid for it. And we were able to quantify what was pro-mental health, what was neutral, where there were problems. And in fact, if you want to look at those data, that's on right now on the Matheson, MATHESON website at the University of Utah for our health economics group. But there's an understanding. We presented those data to GASA and to the other international group interested in stigma. And they're fascinated by it and want to emulate this in their countries. So there is a growing international understanding and priority towards this. We're developing tools to create lasting culture change, to lead to equality and parity for our patients and for ourselves. And what I tried to do today was just use 3 examples to emphasize the power that all of us have to make a difference. To make a difference for our patients, to make a difference for their families, to make a difference for ourselves and our society. Thank you for the opportunity of sharing a little bit of what we're doing. And I hope that you will all join in this effort over the next few years. These are my collaborators for Stop Stigma, the main collaborators. These are some of I tried to get the ad council and folks to give us specific names. And they said, oh, there are too many names that were involved in this campaign, hundreds of names. So these are some of the major groups that volunteered their time and to create the ads you saw. And these are our colleagues at the Sorensen Impact Institute and the Health Economics team. Thank you very much for your time and attention today.
Great, well, I'll slide back in here because we do have a couple of questions, and folks online, if you have any more, go ahead and type them in. We've got about 3 minutes for questions, so. So real quick here, Dr. Rappaport, thank you very much for your talk and all the great work you do. So I have a question regarding neurodiverse populations and mental health crises.
Yes.
Did your team notice any patterns in neurodiverse populations and their mental health over the years? Any other mental health challenges that your team has noticed in neurodiverse people?
Awesome, thanks for the question. This is a wonderful setup, and I'll tell you why. At the University of Utah, we developed a program. The acronym is the HOME program, and I could never tell you what the actual terms are. The HOME program is a program that provides complete wraparound medical and dental care for neurodiverse individuals that have psychiatric symptoms. We have over 1,400 patients and families involved in this program. This is a Medicaid-funded program. We have demonstrated that prior to entering this program, the average cost per person per year is $27,000 per person per year. After being in the program 2 years, the average cost per person is $12,000. This is an at-risk program. But we not only have been able to thrive, and more importantly, the patients thrive, and we've been able to grow it, and it goes from birth until death. We have folks in this program that are in their 60s. We have folks that are kids. It also decreases the restrictiveness of living of these individuals. So it's a really cool program. It was actually part of a National Academy Symposium about 2 years ago. But again, we're glad to share what we're doing, glad to have folks come out and look at it. And it's a really, really important program. Now, there's a real challenge because I would not say that Utah is wonderful when it comes to other aspects of this. We need more residential living facilities for folks who are neurodiverse. We have an initiative that I hope will get completed this next year where we're actually converting a part of our inpatient unit, one of the inpatient units, to individuals, for individuals that are neurodiverse, because they don't do well in a unit that is as active as many of our other acute inpatient units are. And also the staff needs to be trained in a way that's different than acute mental health staff. But we should be opening up this unit in the next year because it's really, really very important to do so. It's been, so Jürgen, this has been an area where I've been bugging our legislature a lot because there's a need for, you know, a true continuum of care, and at least in Utah that doesn't exist.
Well, we have very similar problems here. We actually had a long conversation about this just yesterday. And these are individuals, you know, there aren't that many of them. It's not an unsolvable problem, but they don't fare well and there's a handful of them on each inpatient psychiatric unit, and they don't fare very well there. Yeah.
Yeah,
absolutely right.
and it's more costly to do it that way
Yeah.
because you end up with 1-to-1s and 2-to-1s, and it's a much
That's right.
not the right way to care for folks. It's not humane. All right, I've pontificated enough on that one, I guess.
All right, there's one more question here, so we'll do this one as well, and this person says, thank you again for joining us. I found it interesting that the number of psychiatrists are expected to decrease in the future. Do you think that working on stigma around psychiatric care that medical students have would help increase the number of psychiatrists? And what are some possible solutions you would suggest?
Sure. I think one of them is advocacy, because one of the challenges we have, actually, it's been really cool the last 5 years. More medical students have wanted to go into psychiatry than we had slots. So there's been a real increase in enthusiasm around medical students interested in psychiatry. The problem has been, many of you probably know this already, and I apologize for saying this, but remember, GME slots do not come to schools of medicine. They come to hospitals. And then the GME slots and the IME and DME dollars, the indirect and the direct dollars, have to be transferred to the various programs. And also, by the way, the different health systems send different amounts of indirect medical education dollars back to the programs themselves. That's by way of digression in certain ways, but one of the problems is since 1996, the number of slots available have been capped. And so what happened is many programs have prioritized the slots towards other specialties, partially because psychiatry's been considered a money loser, and partially because we weren't all that popular for many years. So there is a real need for advocacy and for us to advocate for more training slots in psychiatry. The one exception is if you have what's called a virgin hospital. If you have a hospital that does not have existing training programs, that hospital can apply and get new slots. So that is the one sort of exception to that rule. But for example, in Utah, as is I'm sure the case here in Washington, we've had to go to the state and get the state to pay for a number of our slots. We've gone to the state of Idaho because we have an Idaho track and gotten them to pay for a number of our slots. But there's a true need for this. There have been a closing or a decrease in number of psychiatry training programs because of people shifting resources away from mental health and towards orthopedic surgery, towards neurosurgery, towards other aspects of medicine because of the cost basis. That's a great question, and thank you for asking it.
And I think we are actually fortunate here. We have pretty substantially grown our psychiatry residency program in the last couple of years because we've got additional state support. Because I think you look at state of Washington, we're not as bad off as some of the other Pacific Northwest states, but about half of the counties in our state don't have a single psychiatrist, and our legislators hear about that, and they were, and it was a very bipartisan support. They were open to saying, we have a good program, let's train some more. And so we have actually grown our program here. And we have not, I think our parent organization has been nice to us in that they have not substituted orthopedic residency slots for us. We're probably not making the same kind of money, but I think we're probably adding value in other ways. So.
Well, the other thing that talks about is the sophistication and savvy of the chair. It does. And the amount of time and effort that your chair spends engaging with the state legislature, engaging with the governor's office to make that successful.
Yeah, that is true.
All right.
All right, so yeah.
Thank you for a wonderful presentation. Thanks again for coming and joining us. And for those of you who would like to see it, Jed will have this online here shortly.
Yes, we will. And please plan to join us again next week, next Friday, same time, same link. Have a good weekend, everybody.
Bye.